Usually when we talk about medical diagnosis, there's this expectation of precision.
Right, like a clear-cut answer.
Exactly. I mean, you break your arm, the X-ray shows a jagged white line, and the clinical path is just binary. It's broken or it's not broken.
Yeah, there's no real debate there.
But you step into an obstetric emergency, and that X-ray machine is, well, it's essentially useless. You're suddenly operating in these diagnostic muddy waters, where the clinical picture is just shifting by the second.
It's incredibly volatile.
Yeah, and the stakes literally could not be higher, especially considering that roughly a quarter of all maternal deaths globally are tied to one very specific complication, postpartum hemorrhage, or, PPH.
It is arguably the most urgent diagnostic puzzle in modern obstetrics. And what makes it so critical for us to analyze in this deep dive is that mastering PPH, it goes way beyond just memorizing vascular anatomy.
Right, it's bigger than that.
Oh, absolutely. We are really looking at a masterclass in how clinical systems and definitions and simple cognitive checklists can actually intercept human error in the middle of a totally chaotic high adrenaline crisis.
Okay, let's unpack this, because our mission today for you, the listener, is to really demystify how modern medicine tackles this ancient threat. We're going to explore the actual physiological causes of why a patient hemorrhages after birth, and we'll decode this framework known as the 4 Ts.
Which is a brilliant life-saving checklist.
Totally. But we also need to examine the controversies in the sources, like the fierce debates over how to even measure blood loss in real time, and why this entire standard of care is actively evolving right now.
Yeah, and to really grasp that evolution, you have to look at how the target itself has moved over time. Because before a clinical team can, fix a hemorrhage, the system has to agree on what actually qualifies as one.
Which sounds like it should be obvious, but it's really not.
No, not at all. For decades, the traditional baseline, which the World Health Organization still references, by the way, defined PPH strictly by volume.
Okay, so just a strict number.
Right. It was 500 milliliters for a vaginal delivery and 1,000 milliliters for a C-section, all within 24 hours.
Which, I mean, on the surface, that feels like that clean binary X-ray we mentioned. But the sources highlight a pretty major pivot that happened in 2017.
Yes, a massive shift.
Right, because the American College of Obstetricians and Gynecologists, ACOG, they basically threw out those separate thresholds. They bumped the vaginal baseline up to 1,000 milliliters, regardless of how the baby was delivered. And more importantly, they layered on this clinical criterion.
If we connect this to the bigger picture, the problem with a fixed numeric threshold is that it completely ignores the actual physiological reality of the specific patient in the bed.
Right, because everybody's different.
Exactly. By requiring either 1,000 milliliters of loss or blood loss accompanied by signs of hypovolemia like a rapid heart rate or low blood pressure, ACOG shifted the focus from just the fluid volume to the patient's actual hemodynamics.
Okay, I think I get it. So a small-framed woman, for example, she might have a severely constricted vascular space if she has preeclampsia, right?
Precisely. She might start crashing at just 700 milliliters.
But then another patient who maybe has robust pregnancy-induced hypervolemia, like she has extra blood volume just from being pregnant, she could potentially lose 1,200 milliliters and still have perfectly stable vital signs.
Spot on. So a medical field that's usually defined by extreme precision realized that a static number just wasn't capturing the real clinical danger.
But looking at the measurement history in these sources, the actual methodology for tracking that blood volume is just staggering to me.
It's definitely a contentious topic.
Wait, so for decades, doctors and nurses were just visually eyeballing how much blood was lost on pads and sheets, just looking at it and guessing.
Yeah. Visual estimation was the undisputed standard of care for generations. And it was fundamentally flawed.
I mean, it's like trying to guess the weight of a packed suitcase just by looking at it from across the room. The human eye might process the dimensions, but you cannot possibly account for the density.
That is a perfect analogy. And when you factor in that you're dealing with blood mixing with amniotic fluid and soaking into heavy hospital fabrics, visual estimation isn't just difficult, it's basically mathematically impossible.
And the data backs that up, right?
Entirely. Multiple systematic reviews show that visual estimation underestimates true blood loss by 1/3 to 1/2.
Oh, wow. A half.
Yeah, and the psychological component is what makes it so terrifying. Paradoxically, the larger the hemorrhage, the worse the human brain is at estimating it.
Wait, really? So when it's worse, we are worse at seeing how bad it is?
Exactly. When a patient is losing massive, catastrophic volumes of blood, the clinical team's visual estimate becomes increasingly conservative. The human brain just sort of goes into denial.
That cognitive blind spot that just totally explains the massive push in the last decade toward QBL, quantitative blood loss, meaning they literally have to weigh the suitcase now.
Right, you have to put the blood-soaked materials on a scale. QBL requires the team to weigh the lap pads, the underbuttocks drapes, subtract the known dry weights of those textiles, and then meticulously measure the fluid in suction canisters.
Which ACOG and ATHON now demand as standard practice. But implementing that on the hospital floor must have been incredibly disruptive.
Oh, it caused a massive uproar.
I can imagine. I mean, stopping to calibrate a scale and weigh bloody gauze while a patient is crashing. It feels totally counterintuitive to the urgency of an emergency.
It really was met with tremendous resistance. It's a hugely disruptive workflow when every single second counts. But the patient safety movement pushed it through because the alternative, just relying on a flawed visual estimate, was leading to delayed recognition.
And delayed recognition costs lives.
Exactly. That's exactly what drives the mortality rate.
So if visual estimates were just systematically failing for decades, it completely contextualizes why the medical field had to restructure its entire behavioral response.
Which brings us to the real core of this deep dive, the 4 Ts.
Yeah, and the architecture of the 4 Ts is fascinating, mostly because it was born out of a very dark reality.
What do you mean?
Well, in the late 90s and 2000s, state-level maternal mortality review committees, particularly the California Maternal Quality Care Collaborative, the CMQCC, they began aggressively auditing these deaths.
Okay.
And the hard data they published revealed that a significant portion of hemorrhage deaths were not caused by untreatable exotic diseases. They were preventable.
Preventable. So why were they dying?
Patients were dying because the clinical response was disorganized, people were panicking, or they were waiting for an attending physician to arrive to sort of divine the source of the bleeding.
So they essentially took the ABCs of trauma resuscitation, airway, breathing, circulation, and they just built a trauma bay checklist for obstetrics. That is the exact mechanism of action, yes. Through programs like the ASO course and those early CMQCC toolkits around 2009 and 2010, the 4 Ts were formalized.
Because it bypasses the cognitive overload.
Exactly. During a crash, clinicians can freeze or develop tunnel vision. The 4 Ts turns this open-ended panicked mystery of why is she still bleeding into a lightning-fast differential diagnosis.
Let's break down the physiology behind that differential then, starting with the overwhelming majority of cases. The first T is tone, specifically uterine atony.
Right, which accounts for roughly 70 to 80% of all PPH cases.
With a failure rate that high, why isn't the standard of care to just intervene surgically right away, instead of relying on a bedside checklist?
Because the natural physiological mechanism of childbirth is incredibly robust when it works, and invasive surgery carries severe morbidity risks.
Okay, fair enough.
To understand atony, we have to look at how the body naturally stops bleeding after the placenta detaches. Most people assume it's about clotting, but it's not driven by the coagulation cascade. It is entirely mechanical.
The spiral arteries.
Yes. The uterine muscle, the myometrium, is this dense, interlacing network of fibers. When the placenta separates, those torn spiral arteries are just exposed and bleeding. The only way to stop that high-pressure flow is for the uterus to contract violently, clamping down like a fist to physically strangulate those blood vessels.
So if the muscle stays soft or boggy, those arteries just bleed freely into the cavity.
Exactly.
Here's where it gets really interesting. The sources mention that carrying twins or having excess amniotic fluid polyhydramnios are major risk factors for this.
Right, because of the physical stretch.
Yeah, if you think about the interlacing fibers of the uterus, like a rubber band or maybe a woven Chinese finger trap, normally the harder pulls together, the tighter it grips the vessels.
Right.
But if that trap is distended way beyond its structural limit by twins, the muscle fibers stretch out. They get fatigued and they lose their snapback force.
That is an excellent way to visualize the structural failure. Prolonged labor induces a very similar kind of muscle fatigue. And that mechanical failure is what we call tone.
Okay, so let's create a clinical dilemma for you. The nurse pushes on the patient's abdomen. The uterus is clamped down tight as a rock. The tone is perfect, but the blood is still pooling. The mechanical fix worked, but the patient is still bleeding out.
That immediately forces the clinician to move down the checklist and look for the second T trauma.
Which accounts for about 20% of cases.
Yes. When tone is resolved, the bleeding is almost certainly a structural injury somewhere along the birth canal. We are looking for lacerations, concealed hematomas, or, in catastrophic cases, uterine immersion.
That's where the uterus actually turns inside out, right? Often from excessive pulling on the umbilical cord before the placenta has fully detached.
Exactly. It's often an iatrogenic injury, meaning it's caused by the clinical management itself.
This specific T trauma was actually central to Serena Williams' highly publicized postpartum crisis back in 2017.
Oh, yes. That case was a major cultural touchstone.
Yeah, she had a hematoma at her C-section site, combined with a pulmonary embolism. Well, it wasn't textbook atony. It falls squarely into trauma. And it catalyzed this huge national conversation about maternal morbidity and specifically racial disparities in having your symptoms actually believed by medical staff.
Her experience forced a really critical structural review within health systems. It highlighted that even with all these checklists in place, the speed at which a patient's self-reported symptoms are evaluated is still a variable that hospitals have to rigorously monitor.
But going back to the bedside assessment of trauma and tone, there's a massive misconception here. I want to ask you about this. If a nurse feels the patient's stomach and the uterus is firm, they are safe, right?
Absolutely not, and that assumption has tragically cost lives.
Wait, really?
Yes, a firm fundus is not a free pass. You could have a patient with a perfectly contracted, rock-hard uterus, but if they have a severe undiagnosed cervical laceration, which is trauma, they will continue to hemorrhage briskly. Yeah, the firm uterus only clears the very first box on the checklist. The clinician is still obligated to visually inspect the entire anatomical tract.
Which brings us to the third scenario. The uterus is firm, the clinician does the visual inspection, and there are no lacerations, no structural trauma at all. But they are still leaking blood. What else could possibly be leaking?
That points directly to the third T tissue.
Retained placenta.
Yes, retained placental fragments or blood clots, which make up about 10% of these emergencies.
But if even a tiny fragment, like a millimeter of the placenta, is left behind, how does that cause a massive hemorrhage?
Because it disrupts that Chinese finger trap mechanism you mentioned earlier.
Okay, how so?
The uterus cannot contract uniformly if there is a foreign mass occupying space inside it. The muscle fibers around that retained tissue stay stretched out, which leaves a localized area of spiral arteries completely uncompressed and bleeding.
Got it. And the most aggressive pathology in this category from the sources is the placenta accreta spectrum, right?
Yes, where the placenta essentially invades the uterine wall.
And this was my biggest aha moment from the reading. The data is chilling. The massive rise in placenta accreta tracks almost exactly with the rising global C-section rate.
The pathophysiology behind that link is entirely rooted in how scar tissue alters the uterus.
Right, because a prior C-section leaves a physical scar on the uterine wall. And when the patient gets pregnant again, the new placenta often implants over that compromised scar tissue.
Exactly. And in an attempt to find adequate blood supply, the placental cells dig deeper. They invade the muscle wall because the normal physiological barrier was structurally damaged by the previous surgery.
So a surgery that was designed to make childbirth safer today is essentially planting the seed for a severe hemorrhage risk years down the line.
It's a downstream cascade of interventions, yes.
That is just wild to think about. Okay, so that leaves the final, and I think most complex, T thrombin.
Thrombin is very rare, about 1% of cases, but it is disproportionately lethal. This is coagulopathy.
So the plumbing is fine, the structure is fine, the cavity is clear, but the blood simply won't clot.
Right. Conditions like severe preeclampsia or an amniotic fluid embolism can trigger DIC, disseminated intravascular coagulation. The body forms microclots everywhere, which rapidly consumes the entire reserve of clotting factors.
What's fascinating here is that thrombin is the only category where mechanical fixes are completely useless. Right?
Exactly. You cannot massage a clotting disorder. If you put in a uterine balloon, it won't help. You must replace the blood products via a massive transfusion protocol. You have to rebuild their capacity to clot.
Okay, so knowing the 4 T's tells clinicians why it's happening, but how do they proactively stop it? This brings us to the fierce debates over intervention, like active versus expectant management.
Right. Intuition suggests that for a low-risk patient, you just practice expectant management, let nature take its course, and withhold drugs.
But the sources say that's totally wrong now.
It is. Large trials prove that a massive portion of atony cases happen to women with absolutely zero identifiable risk factors.
So you can't predict it.
You can't, which is why active management is the standard. Giving a uterotonic drug like oxytocin to every single woman immediately after birth. It chemically forces the uterus to contract.
And when that fails, we look at the woman trial from 2017, tested on 20,000 women across 21 countries. It proved that tranexamic acid, or TXA, drastically reduced bleeding deaths.
Yes. It's a cheap, decades-old generic drug that stops the body from breaking down its own early clots.
But there's a dramatic catch here. TXA only works if given within 3 hours of delivery, right?
Timing is literally everything. If given after 3 hours, the patient's coagulopathy has shifted phases, and TXA offers absolutely no survival benefit. In fact, it could cause dangerous blood clots.
Wow. Okay, as we wrap up this deep dive, I want to address you, the listener, directly. Because there is one last dangerous misconception about timelines that you need to know. A lot of people assume the danger window closes when the mother leaves the delivery room.
Oh, that is a huge mistake. We have to talk about secondary PPH.
Right, the 12-week danger zone.
Exactly. A patient could be home weeks into recovery and suddenly experience a massive hemorrhage, often from a tiny retained placental fragment that causes an infection. It can strike completely out of nowhere.
So what does this all mean? When you look at everything, the 4 T's essentially compress a life-or-death mystery into a seconds-long bedside checklist. It empowers nurses and midwives to act instantly without waiting for a specialist.
It's the ultimate example of clinical systems overcoming human error.
It really is. But I want to leave you with a final thought to mull over. Since rising C-section rates globally are quietly driving up the rates of placenta accreta, are we currently manufacturing a future epidemiological crisis? In our modern quest to medically manage childbirth for immediate safety today, are we unknowingly engineering the very hemorrhage crises that the next generation of nurses and doctors will have to fight? Definitely something to think about.